Hi everyone, my name is Harrison Steins, and I am here to talk about critical care echocardiography, or at least the way I think about performing a more comprehensive cardiac focused exam with ultrasound. A bit of background about me. I am currently a fourth year medical student. I'm interested in emergency medicine and austere medicine and wilderness or resource limited medicine and how we can apply ways we perform actions in the hospital in environments without the necessarily correct tools or without the abundance of tools that we see them in the hospital with. I'm also a master's candidate for the College of Remote and Offshore Medicine in austere and austere critical care. At my medical school, I'm a predoctoral clinical ultrasound scholar. So I'm in the inaugural class of people who've really liked ultrasound and want to see it progressing in medical education. So I'm making this lecture because I've gotten to the point, and I know many of my colleagues have, in medical school at least, as well as people I've worked with in EMS and pre-hospital care, whether it be from the flight side or the ground-based transport side, or some military colleagues. We've gotten to the point where we have exhausted the ultrasound knowledge with FAST, with brush, with AAA screening, IVC, checking for volume status of patients. And I thought, with my probe already on the chest, I'd love to know more. But I think that the overwhelming amount of information around echocardiography and what, as maybe emergency medicine providers, and obviously I'm not an emergency medicine physician yet, but I hope to be, but what we can pull from that in kind of the basic exams that med students learn and pre-hospital providers learn is exhausted, right? So I'd love a more comprehensive way about going at looking at the heart without necessarily having the experience or knowledge of a cardiologist or an intensivist in the ICU that's looking at these advanced exams. So I went through the literature, I went through countless videos, spoke with many physicians, and kind of looked through all the information out there and developed my own lecture on a condensed version of echocardiography for a emergency medicine critical care provider. And in effort to expand my knowledge base, I wanted to record this lecture so I could help anyone else looking for the same. So what we're going to do today is go through an introduction into the 5 major cardiac windows and the views of the heart. That will include the IVC, subcostal view. We're going to talk a little bit about performing proper cardiac ultrasound technique, evaluate and how we're going to evaluate for major cardiac ultrasound pathology, spending a bit of time looking at evaluation of left ventricular ejection fraction and how ejection fraction plays into our understanding of pathology, and then estimating central venous pressure for fluid status, fluid tolerance using the IVC, which if you've done the rush exam or things like that, you've most undoubtedly learned already. So our exam overview, the first thing to note is that multiple views are obtained in each window. So some parameters, like the measurements we'll be taking of the left ventricular diameter, can be evaluated in several different views in order to assess the reliability and reproducibility of these measurements. Starting off with positioning, we're going to look at the parasternal long axis view, the parasternal short axis view. Then moving into the apical views, we'll do the apical 4-chamber, 5-chamber, and 2-chamber view. You can look at other multi-chamber views of the heart, but in my research, I kind of decided to focus on these. And then coronary sinus view, subcostal view, subxiphoid, and IVC view. Important to note patient positioning. The parasternal and apical windows are obtained with the patient in the left lateral decubitus position. That is, if they can actually get into this position. And then the subcostal suprasternal windows are obtained with the patient in the supine position. So moving on to a note on measurements. The chamber measurements constitute key parameters of each of these exams. So we'll be looking at anterior-posterior measurements, looking at measurements from internal to internal, external to external parts of the muscle, or parts of valves. It's important to note exactly where these measurements are starting to come from so that they're standardized across both the measurements that we're using to determine pathology or normal, as well as being able to communicate all of our findings effectively. So the ventricular measurements made using the electronic calipers on the ultrasound machine are measured with the tips positioned the interface between the compacted myocardium and the non-compacted myocardium, the trabeculae. So the bundles of muscles that are projecting from the inner surface of the ventricle of the heart. And they're kind of like sponge-like network muscles used to provide support to the heart. That's where we'll be taking one of our measurements to the compacted part. So the non-sponge-like, non-trabeculae part of the myocardium. So other dimensions, including the atrial dimensions, the mitral annulus, aortic annulus, and a couple others that we're going to mention, are measured using the blood tissue interface. So this is the inner edge to the inner edge. These are important because if you obviously these measurements can be small, so if you are measuring inner edge to outer edge, you're not in line with kind of best standard practice, and you're not actually getting the real measurement. But two, you could call something pathologic or non-pathologic when it actually is. So moving straight into our parasternal long axis view. This is a view that's going to be showing mostly the left side of the heart, leaving that right ventricle, right atrium out of our main view. We'll be looking at the left ventricular outflow tract, let me see if I can turn on, oh, here, perfect. So we're going to be looking at kind of starting in, we'll actually go through like left atrium, coming into left ventricle with mitral valve, coming into left ventricular outflow tract and the aortic valve. We want to be able to see a little bit of the right ventricular inflow tract up here into part of the right ventricle, but that's not the focus of this exam. What we're looking at is really, are the structures well defined? Are there vegetations that we can see? So anomalies of bacterial growth, of evidence of something like endocarditis. I want to see that the movements are uniform. So looking at something like the mitral valve, are both the leaflets co-opting, aka coming together fully? Is one coming together more? And then are the muscles of the ventricles of the atria closing in and opening up in systole and diastole in uniform size relative to the time in the cycle and relative to the other structures. So say looking at collapsibility of the, or not collapsibility, but closure in systole and diastole of the left ventricle compared to the right ventricle, looking at the interventricular septum, which is right up here, to see, is it bowing one way or the other or something like that. So once we've taken that parasternal long axis view, this initial bit of information into structure of the left ventricle, left atria, and the rest of these structures on here. So next we're looking at the left ventricular outflow tract, and here we're going to be taking a measurement using the calipers on the ultrasound. So the left ventricular outflow tract is a critical measurement to understanding aortic stenosis. So if we remember the aortic valve closure by cooptation, where the valve leaflets come together, happens during ventricular diastole. So as the heart's filling, you don't want anything to be spilling out into the aorta. And in systole, the systolic wave of pressure from the heart contracting can dilate the region, opening up those leaflets. So we utilize the diameter of the left ventricular outflow tract at the end of systole, and so systole where everything is dilated, as a reliable estimation for aortic valve area, and from that we can conclude whether or not there's aortic stenosis. So this measurement's really important as to where we take the measurement. You can see kind of the purple line right there would be the measurement of where your calipers would be, and it's measured near the aortic annulus at the base of the leaflets. A trick that I was looking up was that the aortic annulus and left ventricular outflow tract are measured in mid-systole and inner edge to inner edge. So everything on the aortic side of the annulus is then measured in end diastole and leading edge to leading edge. So there's historical precedent behind this based on the progression of ultrasound and where people were taking measurements. It was thought to take inner edge to inner edge and leading edge to leading edge, everything on the aortic side, so that you had greater capture and more sensitivity of these measurements, i.e. you weren't underestimating the diameter of this measurement and missing people with aortic stenosis. So once you measure near the aortic annulus at the base of the leaflets, your left ventricular outflow tract measurement should typically be around 2 centimeters. And so you want to be measuring within 0.5 to 1 centimeters of the valve orifice. So the valve orifice, the aortic opening, it's a circular opening in front of and to the right of the left ventricular or atrioventricular orifice, and it's separated by the anterior cusp of the bicuspid valve and guarded by the aortic semilunar valve. So once we've taken the measurements of the left ventricular outflow tract, we can move to a visual inspection of the aortic valve. And similar to all the valves we'll be inspecting with ultrasound, we want to be looking for a couple of major things. So in our visual inspection of the valve, we want to see that the valves are moving apart and coming together in systole and diastole properly. And what I mean by properly is that there is symmetric motion on both sides, that the valve leaflets are coming together fully, cooptation is what it's called, of both of the cusps, so that there's not irregular blood flow from one area to another area over a valve that hasn't come together well. We want to be looking at both valves, and in this case, 3 valves, although we can't necessarily see the non-coronary cusp. But for this case, the right coronary cusp and the left coronary cusp don't have any vegetations on them. Vegetations on ultrasound look like irregular, there's an EM term, the Goomba for them, but irregularly thick projections onto a valve, an area of high echogenicity, so an area that's hyperechoic, a bright white structure that wouldn't necessarily be there or is only present on one valve cusp but not the other. So once we've assessed that the cusps are without irregularities like hyperechoic structures, and they are moving in systole and diastole symmetrically and with the other valves, and they are coming together, then we can go on to add color Doppler over both the LVOT and the aortic valve, looking for aortic regurgitation. So if the aortic cusps are not coming well together, not co-opting, then there might be abnormal blood flow moving from one area to another because the blood is able to move during both systole and diastole. So in diastole, when that valve should be closed, blood is still able to move across it. And what that looks like is a mixed picture on color Doppler. So instead of seeing a single red, a single blue, you see this mixed picture that we can see in this severe aortic regurgitation image. We can add spectral Doppler to measure for aortic stenosis. So spectral Doppler shows the blood flow measurements graphically, displaying flow velocities recorded over time, instead of displaying Doppler measurements visually as in the color Doppler and power Doppler modes. And then finally, you can measure the diameter of the aortic annulus. And this image on here on the bottom has our tips that we used in the last slide. Here is a parasternal long axis view of the aortic valve. So in this first one, we see normal movement without restriction of, we can pull in right here, of this aortic valve. The second one, we see a heavily calcified, so hyperechoic, very bright white aortic valve leaflets, and there's restriction to flow on systole. So as the heart's trying to contract, you're not seeing that symmetric and powerful opening of the aortic valve cusps. They're heavily calcified, where we can see this bright white area, whereas we don't see that on these two cusps, on the right and left aortic cusps. So once we have looked at the aortic valve, we can start moving down the line to the aorta. So we want to be visually assessing the valve. So there's a couple of different parts that we're going to be going through as we visually assess the aortic valve. Starting with A, B, C, D here in the bottom left, we start with the aortic annulus, then go to the sinus of Valsalva, the sinotubular junction, and the ascending aorta. I think that it's important to note each of these different sections, but it might not necessarily be on your radar to be taking measurements at all of them. If we're looking for something like an aortic aneurysm, which is a dilation of the aortic root, the ultrasound image could be showing an intimal flap. So an intimal flap consists of a dissected aortic intima, which is separated from the aortic wall. This intimal flap separates the aortic lumen into a true lumen, and that's a lumen where blood is flowing, so a passageway that blood flows, and a false lumen, aka like a hematoma, where blood is going to be stored. So what we can end up doing is looking with color spectral Doppler to determine the flow signals. So if you have a false lumen and a true lumen, one where blood is in stasis, not necessarily starting to coagulate, but not flowing, and then a true lumen where blood is flowing, we can use pulsations of blood and movement of blood under an ultrasound transducer to determine if there is blood flow or if there is not. And that can help us look at a intimal flap. So we're looking for aortic aneurysm here. You can take measurements of the linear segments of the aorta. And in image A, we have that. So you'll be taking your aortic valve diameter, sinus valsalva diameter, sinotubular junction diameter, and ascending aorta diameter. And these are going from lumen to lumen, as we kind of talked about in our previous slides, where past the aorta is lumen to lumen. And then here's a cutoff value. So in men, say like you're looking at the sinus of valsalva, that should be greater than, or shouldn't be greater than 4 centimeters. Moving on, we have the PLAX view of the left atrium. So left atrium, we're really looking at the size of the left atrium. And that size should range from 1.8 to 4.0 centimeters. We're looking at the anterior-posterior diameter. And we can see it here on this right image. So we're going from that point of Valsalva, or the sinus of Valsalva, where we just took a measurement on the aortic measurements slide, and we're going perpendicular to the plane of the left atrium. So we're going to measure an end systole, and hopefully this shouldn't be affected by artifact, but down here you can see there's a little bit of noise going on. Moving on to the left ventricle. So we start with a visual assessment. So again, the left ventricle is one of the main chambers that we're focusing on. It's the heart's main pumping chamber. It pumps the oxygen-rich blood into the body's main artery called the aorta. Obviously, it's implicated in heart failure, and we'll get to that when we start talking about ejection fraction, which is your heart's ability to pump the oxygen-rich blood out toward your body. But in our first visual assessment, we want to look at the basal and midventricular septal portions. We're observing if the walls of the left ventricle, are they pulling in evenly? So from outside pericardium, this white bright structure, is this external wall pulling in evenly with the interventricular septum? Are they pulling in too much, not enough? Is one side pulling in more than the other? And then we're looking at mitral valve function. How does it close? How close does it come to the interventricular septum? And the closer it comes, the better. We can use that, and we'll start talking about estimations of ejection fraction just by eyeballing that mitral valve and how well it's co-opting, and then how well it's slapping against that interventricular septum and the septal wall. We're going to assess wall motion during systole. So all myocardium should thicken on systole as the heart's trying to squeeze out all of that blood and travel toward or travel away from each other during diastole. Then we can measure the diameter at end systole and end diastole and compare to how to come up with an estimation of the size of the left ventricle. And then color Doppler may occasionally detect a VSD, showing blood flow from the left ventricle to the right ventricle or right ventricle to the left ventricle. So moving on to a PLAX view of the right ventricular inflow tract. This isn't a view that I really get all the time, but so in the parasternal long axis, it's the only view visualizing the posterior leaflet of that tricuspid valve, and you're really assessing leaflet coaptation. And then you can, again, use color and pulse wave Doppler to examine the tricuspid valve. This little Sono snack tidbit that I found was great. It talks about why we're doing this, looking at endocarditis, looking for regurg, again, with that color Doppler or pulse wave Doppler. Is there a thrombus in the IVC, right atrium or right ventricle? And then visualizing that coronary sinus, assessing a pacemaker and an ICD wire, which there should be in the bottom right there. And then for fun, really, which ultrasound's all fun. So I think that's a good way of looking at it too. Next, what we'll be doing